Now, the urethra is a tube within the penis that conveys semen out of the body during ejaculation. Glans, the rounded, highly sensitive head of the penis. Prepuce, a fold of skin covering the head of the penis. This is the fold of skin, foreskin. This is the glans. Now, external penile structures, corona, the rim of the glans penis. This is the corona. And this is the frenulum. The glans, the urethral opening here, this is the foreskin. Now the frenulum is the thin strip of skin connecting the glans to the shaft on the underside of the penis. Both are highly sensitive areas to touch. Blood supply of the penis. Now, veins drain into the internal pudendal veins. Arteries, the corpora cavernosa, are supplied by the deep arteries of the penis. The corpus spongiosum is supplied by the artery of the bulb. In addition, there is a dorsal artery of the penis. All the above arteries are branches of the internal pudendal artery. Now, lymphatics and innervation of the penis. Nerve supply, sensation, the nerve supply is from the pudendal nerve and the pelvic plexus. Erectile function, parasympathetic, excitatory and sympathetic inhibitory. Lymphatic drainage, the skin of the penis is drained into the medial group of superficial inguinal lymph nodes. The deep structures of the penis are drained into the internal iliac lymph nodes. Now, circumcision is a surgical removal of the foreskin of the penis. See the different steps. Now, the circumcision in the Muslims, it's a ritual. And actually, I would, if I were the course director of the medical education, then I would request that you must attend, a doctor or surgeon should attend the ritualistic practice of the Muslim of circumcision. Because in mass, 50, 100 boys are circumcised on the auspicious day or month, and you see there is no panic practically. There is no panic among the children and also the parents, especially the mothers. They don't panic. I had one family invited me in such an occasion but they wanted me to do 3-point circumcision. And as usual, I took my xylocaine injections to make it anesthetized locally, and then I circumcised. But the skill, and that is the one clamp, that is the hajam, who performs this is actually Babar community. Naturally, they clamp it in such a way that when they cut off the foreskin, there is absolutely minimum bleeding. Of course, the foreskin, whatever is evident, is nowadays they are using some antibiotic powders or lotion or anything and leave it. And we are putting sutures, okay, but at times what happens, in the frenulum part, the foreskin is with the frenulum. Now this is excised. this portion. Of course, this skin is excised. Circumcision. Actually, over here, we put a suture in this format, triangular, like this. And we tie it. There is, and 1 or 2 stitches in the periphery of the glands with the foreskin and the penile skin. And we secure hemostasis. At times, the circumcision done, say if they do 50 circumcision, 1 or 2, there might be a secondary hemorrhage on the second day. So they go to the hospital and we give sutures, and that is managed in that way. But one thing, see, why I am telling you, the Hindu mothers, if the child has a phimosis, now the foreskin is not retracted. A small opening, and if you ask that what is the problem, the mother says that it's difficulty in urine, passing urine, and there's a swelling of the foreskin. The urine collects there actually. The urine collects in this portion. Now, if this is the urethra and the glands here, in this part it swells like this. And sometimes there is infection or something. Now, if a child of just 6 months or 1 year old, you see, you try to retract, but if you see a very small opening, you just put a small hemostatic forceps, not in the urethra, and around the, and you just stretch a little bit. Under xylocaine jelly, you soak it or xylocaine spray, and then you leave it and try to retract how much you can. At least the meatal opening, if it is retracted, then at a later stage, later when the child grows up means not at 16 or 17, but we even come just before marriage, the male person coming with for a circumcision. So, one thing, now this is the procedure, how your removal of the foreskin of the penis. And this is the dorsal slit. This is under all local anesthesia. This can be done under local anesthesia. Actually, the other day I showed you a boy of 6 years or 5 years. I give them a Cadbury lollipop and they suck and we talk, and I don't wear mask or anything. So the fear is gone. And indeed, now any children are coming to me at this stage. That time, what I do, I tell them to see video. I tell them to sit in my office. I give them some chocolate and they see the video. And the first day, I go for an investigation, routine blood test and all this. And then next day, I give a date. Now, he carries home the message that it can be done. It's easy. So, to some extent, the fear is gone. So, excuse me. Now, penile cancer, one of the rarest form of cancer, approximately 1,300 cases in the USA each year. Survival rate is less than half unless it is caught early. Usually begins as a small painless sore on the glands or foreskin that eventually changes into cauliflower-like mass that is chronically inflamed and tender. Risk factors: age over 50, history of multiple partners and STDs, especially herpes, poor genital hygiene, long history of smoking. Left untreated will eventually destroy the penis and spread into the lymph nodes and beyond. Now, if it is Now, what happens if if the skin is here? Now, at part over here where we have growth, and this is covered with poor hygiene and all, the foreskin cannot be retracted. And what happens? Usually, this is to be balanced in this way. It can be done under local anesthesia and partial amputation of the penis. Partial amputation of the penis. Amputation of the penis under local anesthesia. And see, if this is amputated, I have this skin here. Now, this skin will be put in front of the urethra, you pass a catheter, and you make a small hole over here, and you stitch. Now, this is an amputated penis. Now, this skin is put up like this. And over here, you stitch the skin. And you keep the catheter for 20 days and change again. And for 2 months, you keep the catheter and withdraw. And ultimately, the part, and then you send for the histopathological examination. And you will see the total the thing, and then send to the oncologist or department of thing. It does not need so much of the thing, anti-cancer drug, if there is no spread or something like that. Okay? But you have to do it in Rarity. Now, testis. Shape ellipsoid and paired position suspended into the scrotum by corresponding traumatic cord. Left testis 1 centimeter below the right testis. Direction oblique, upper end tilts forwards and laterally. See, the left testis now a man or an adolescent boy, actually they come with pain, epididymis, orchitis can happen. It can be a trauma, and they come to the doctor and tell you that, sir, আমার এই বাঁ দিকের টেস্টিসটা নিচের দিকে ঝুলে আছে. So you have to assure him that this is normal. And it is psychotic component, or he was borderless. But when he has come with a trauma or epididymal pain, acute pain in the testis due to orchitis or epididymal orchitis or an infected hydrocele, then he will point to you that my left testis is below. So you have to, the psychological component of the patient, you have to eliminate and tell him and assure that, no, this is normal. You don't worry, this is normal. Okay? Now, okay. Now, measurement of the testis, length 5 centimeters, breadth 2.56 centimeters, thickness 3 centimeters, weight 10.5 to 14 grams. This is normal measurement. Okay? Next. Now, parts of the testis: two ends, upper and lower, two borders, anterior and posterior, two surfaces, medial, lateral, and epididymis. Okay? Next. Now, upper end of testis overlapped with the head of the epididymis, connected to epididymis by efferent ductules. Now, see, this is spermatic cord, this is cremasteric fascia and muscle, ductus, this is the deferens, vas, pampiniform plexus, this is the epididymis and the appendix of the epididymis, appendix of the testes, and this is the epididymis, this is testis itself, parietal layer of tunica vaginal testis. Now, see, the sessile fibrofatty body represents an embryonic remnant of cephalic part of Mullerian duct. Now, lower end of the testis is connected to the tail of the epididymis by areolar tissue and tunica vaginalis. Anterior posterior of testis smooth and convex. Next. Posterior border broad and flat, attachments posterolaterally, body of epididymis, posteromedially vas deferens, upper border of the posterior border, spermatic cord. Medial surface smooth and convex, lateral surface of testis convex and smooth, overlap posteriorly by epididymis, which is separated from the testis by sinus of the epididymis. Sinus of the epididymis, semilunar process of vaginal sac, helps in determination of the side of the testis. Now, this is important because, see, of course, due to some inflammatory reactions, there might be adhesions, but when you are doing an operation for hydrocele, then actually you have to see the sinus. It will be on your left side, okay, and the right side. The sinus, this part. Actually, what happens when you are operating in a hurry, you just put in. You bring out the testes out of the scrotum and you suture, like the tunica vaginal testis is, but ये दावा उल्टे दावा. This is hydrocele. This like I open my buttons, shirt, open, and now you think the buttons are at the posterior end. So you suture it, take like this. Now naturally, when you have sutured it, and when you are putting the testes into the scrotal sac, you have to observe the sinus. If there is don't like you just like this, at a torsion kore dile, you make it twist it, and if there is a torsion, then there will be acute pain. Post-operatively, no analgesic is working, then you have to reopen. So, though it is a very simple procedure, though it is very easy to operate, under local anesthesia and also spinal anesthesia, but you have to be very much this thing that you put in without torsion, the sinus of the epididymis directed outside. Now, hey, next. Now, the head formed by coiling efferent ductal lobule of epididymis. See, this is the appendix of the epididymis, canal of the epididymis, the body and tail formed by coiling single duct from tail, vast difference begins as a continuous canal of the epididymis. Now, all this will go through this and then go to the somatic cord and go. Now, a patient comes with a male patient comes with sterility, then you have to married for 2 years, 7 years. But in our society, especially Indian society, Boma, the woman is hanged, or for sterility, the woman is to be blamed. So, investigation after investigation, the wife is being put into a battery of tests. But her USG, her histosalpingography, all reports are normal. One thing, but the male, when I see a patient, the lady comes first. I told him that I'm giving you for your problem, I'm giving you for a month. But next visit, your Sasuma did not come, but your husband has to come. Then I will give a treatment. Now, next visit, the husband comes. Then, and I tell the woman that you please abstain from the intercourse for 3 days. And the husband comes, then you do a simple semen analysis. Now, see, there are no lacks of SPG commandos or commanders, special protection group for VIPs or Modi's security. There are 10 or some people. There are other, it's like that. So, to boost up the male, that you have some problem. She doesn't have so much problem. She doesn't have problem, don't say. But she has a problem, but not much. But there's a problem. You need a treatment. Then you have to go to the psychological component, singular, counseling. And then you tell them that you have, say, count is little, say 10 or no sperms. So you go for 3 months treatment and see if the count is increasing or not. And then IVF or whatever it is there, you can opt for, and you give a counseling. 3 intrinsic coverings outside inwards, visceral layer of Tunica vaginalis testis, Tunica albuginea, Tunica vasculosa, and extrinsic coverings. Next. Now, the Tunica vaginalis covers the testis and epididymis except the posterior border. Beyond the testis, visceral layer is continuous with the parietal layer forming a closed vaginal sac. The vaginal sac develops from the distal part of the processus vaginalis peritoneum. Now, the incomplete descent of testes or undescended testes. undescended testes, incomplete descent of testes, it is same. But I would rather choose the incomplete descent of testes, because if you go, this is the peritoneal, it comes into the head. Now, during organogenesis and embryogenesis, the testes are in the abdominal cavity. In the upper level, in the place where kidney is, and kidney is in the abdominopelvic region. Now, the kidneys ascend. Your kidneys ascend and the testes descend. And in the path of the descent, when it is descending, it might be arrested. One side might come down into the scrotal sac, and the others in the here it descends. Okay. And kidneys go there. Okay. Now, undescended testes. Now, this might be, the testes can be here, it can come here, it can be here, it can be in this place. Now, these are the location in the abdominal or in the abdominopelvic region, or it can be in the scrotum. So, your two possibilities are there, that either both the testes don't descend into the scrotal sac, and the other, only one side can descend. And in this pathway, it can be arrested in any place. But nowadays, we are lucky that we are having modern imaging, and ultrasonography is a good tool that you prescribe and to see the location of the testes. Now, this is the incomplete descent or undescended testes, okay? And the peritoneal sac, actually, which I here draw, now during, just after birth, it closes. The processes in bilateral testes. It becomes a thick cord-like. But at times, this does not close. So it becomes a hernial sac. Now, Tunica albuginea, thick fibrous membrane which envelops the entire testis and projects into the interior of the organ from posterior border as an incomplete vertical partition known as mediastinum testis. Forms convex anterior surface of the mediastinum. Numerous fibrous septa radiate and divides into the testis into a number of cone-shaped compartments, lobules of the testis. About 200 to 300 lobules are present in each testis. You saw the picture that the coiled structures, the seminal tubules are there. So, if for a patient of undescended testes, you can take a biopsy of this portion of the testis, okay, and you have to make a small cut and get the specimen, put it, fix it in formalin, and you will go for histology and see the pattern, what is the type, and if there is any chances of, you can see the spermatogonia and spermatocytes, secondary spermatocytes and spermatids. Now, next. Now, tunica vasculosa, areolar and vascular membrane which lines the individual lobules of the testis. Next. Now, extrinsic covering of the testis, outside inward skin, dartos muscle, extrinsic spermatic fascia, cremasteric muscle, cremasteric fascia, internal spermatic fascia, and parietal layer of tunica vaginal testis. Now, these muscles actually, at times it retracts, it contracts, and the testis goes up. Scrotum looks small, and especially in chilly winter, or you're taking a shower, so you can see the changes of the dartos muscle and the cremasteric muscles. You see the changes. Now, arterial supply of the testis, mostly supplemental testicular artery, which is a branch of the abdominal aorta. Testis is partly supplied by artery to the vas deferens, which is branch of superior inferior vesical artery. Sometimes supplied by cremasteric artery, a branch of the inferior epigastric artery. Arteries of testes are longitudinal and anastomose with one another. Now, this can be a short, just 4 marks question. Arterial supply. Hey, কি মজা লাগছে? ভাই অগাস্টে দেখে নেবো, আমি দেখবো না, তোমার ইয়েটা দেখবো, আমি দেখার কেউ নেই। Either you just keep shut and put your head on the desk. এত বলার পর আজকে কি কবে তোমরা ঢুকেছো? তুমি নিউরোসার্জন হবে তো? তাহলে তোমাকে টেস্টিসটা জানতে হবে। আবার নিউরোসাইকিয়াট্রি হলে তোমাকে আরো জানতে হবে। তোমাকে বাচ্চাদের কামসূত্র পড়তে হবে, তবে তুমি একটা ভালো প্র্যাকটিশনার হবে। তখন থেকে দেখছি গল্প করছো। তোমাদের যদি ভালো না লাগে, আমি প্রথম থেকে বলে দিয়েছি যে অ্যাটেন্ডেন্স দিয়ে চলে যাবে। তোমরা বাচ্চা দাও। এটা একটা যারা আর্টস বিএ পড়ে তাদের কাছে এটা হাসির খোরাক হতে পারে। It's like a joke. Now, the venous drainage of testes, 15 to 20 veins from posterior border of the testes and epididymis unite to form tympaniform plexus. This is very important. At superficial ring, the plexus unites, forming 4 veins. A deep luminal ring, they further join to form 2 veins. Finally, single vein is formed in the posterior abdominal wall. Right testicular vein drains into the at an acute angle. Left testicular vein drains into the left renal vein and right angle. This is a very important component for your examination. Where the right testis is your MCQ, where the left testis drain, venous drainage. And also it is a small 2 marks question on venous drainage of testes. It can be a question on Viva. তোমাকে testis একটা gross anatomy তে বললো তোলো এটা, তুমি describe করলে তখন বললো what is the venous supply, what is the arterial supply, where it drains. Counter current heat control mechanism. Heat conveyed by arteries of the testis is mostly absorbed by the veins of the pampiniform plexus. Eventually, scrotal temperatures of testis is somewhat lower than 3 to 4 degrees that of the abdomen. This mechanism of heat transfer is known as counter current mechanism. You might have a note, what is counter current mechanism? Short note. Then you have to describe this part, this, whatever it is there, you have to describe. See, this is one part that hernias, there will be scrotal abdomen. You search in your Google today, what is scrotal abdomen? That's a big hernia with all components, the ilium, cecum, and appendix is in the scrotum. Now, you have to go for an operation, but you have to have the patient, your leg end of the bed, here the cot, okay, now this has to be raised by 2 bricks or blocks, and the person sees now. So your organs has to be trained to be in the abdomen, and ultimately that is the adaptation of the total organs, the abdominal organs in the scrotum. Actually, they get acclimatized to the temperatures. It is very rare. When I was a house staff in Burdwan, I met a patient that was refused operation in Calcutta and other colleges, and he was admitted in Burdwan under our unit, and I had that patient for 2 months in the ward. That time I just house staff, and that time I got the Rodney Mangot. It's a surgical book, operative surgery. Rodney Mangot, in his days, he encountered 4 such cases. My teachers did not want to admit it. So I told them and gave them a reference, and I argued that patient total, I have the responsibility. So that patient was admitted, and we had 1 month in this preparation and all, collecting blood, and that scrotum, acclimatizing from the scrotum to your abdominal temperatures. Lymphatic drainage of the testes drain into the pre-aortic and para-aortic lymph nodes following the course of testicular blood vessels. Now, nerve supply of the testes, sympathetic and blood from the renal and aortic plexus. Preganglionic fibers are derived from the 10th and 11th thoracic segments of the spinal cord. Testicular pain referred to umbilical region due to segmental innervation. So, a patient comes with an umbilical pain, or they'll say that you don't diagnose that as appendicitis. You have your thought in appendicitis, but also you think of it might be this. If it's a male, it's a male patient. Okay. Now, spermatic cord, tubular sheath containing vast different vessels and nerves of the testis and epididymis. Whenever you are in the hall, when you please see the specimen, and when you, if it is in the dissected body, see it and see the layers. अरे एक बारी तो घाटाघाटी करबे. Now extension, deep inguinal ring to upper part of posterior border of testis, length 7.5 centimeters. During descent of testis along the inguinal canal, the spermatic cord receives successively 3 tubular prolongations from the abdominal wall. Now, contents of the spermatic cord, vast difference, campaniform plexus, arteries, testicular artery to vast and peristeric, lymphatics from testes and epididymis, nerves, genital branch of the genitofemoral nerve, testicular plexus of sympathetic nerves, and perivascular coats covers conveys fibers of from T10 and T11, loose to process of the remains of processus vaginalis, accessory suprarenal cortical tissue. Now, varicocele. Now, abnormal enlargement of the campaniform plexus in the scrotum, upward flow of blood in the veins is ensured by small one-way valves that prevent backflow. Defective valves or compression of the veins made by nearby structures can be caused dilatation of the testicular veins near the testis, leading to the formation of varicocele. Now, this can be a defective valve. Compression of vein by a nearby structure can cause dilatation of the testicular veins near the testes, leading to the formation of varicocele. What is varicocele? That can be a short note, 4 marks or 3 marks. Okay. Now, hydrocele. Now, hydrocele, accumulation of clear fluid in the tunica vaginalis testis, usually occurs in one side but can also affect both sides due to trauma, infection or tumor, but causes is generally unknown. Normally is seen in infant boys as enlarged scrotum. In infant girls, it appears as enlarged labia. Now, the testicular torsion here. When the spermatic cord from which the testicle twists, cutting off the testicle blood supply, ischemia. Underlying cause is congenital malformation known as bell clapper deformity, wherein the testis is inadequately affixed to the scrotum, allowing it to move freely on its axis and susceptible to induced twisting of the cord and its vessels. Now, bell clapper deformity. This is the torsion. Now, testicular cancer, testicular mass here. Now, one or both epididymis will noticeably swell, inflamed or hardened, indurated. Yeah. Swelling from epididymis may stretch into the inguinal canal and may appear similar to that of a hernia, particularly an inguinal hernia, classified as acute, subacute, and chronic depending on the duration of the symptoms. Epididymitis. Now, epididymo-orchitis. Now, this is the ureter, bladder, this is vast difference, and epididymis, testicles, inflamed epididymitis, inflamed testicle orchitis. Epididymal cysts, normal groin, and epididymal cyst here. Now, this is important. Descent of testes, 7 weeks, 13 weeks, 24 weeks, newborn. See the testes, previously I told you, and see cryptorganism, anarchism, monoarchism, ectopic testes. Now, cryptorganism, anarchism, monoarchism, ectopia testes. Now, defects in male genitalia, hypospadiasis, incomplete fusion of urethral folds and slit at the inferior aspect, epispadiasis, urethral meatus on dorsum of the penis, and micropenis in insufficient androgen stimulation for growth of external genitalia. Vast difference is 45 centimeters long. It passes from the testis through the inguinal canal and ascends medially towards the posterior wall of the bladder, where it joined by the duct from the seminal vesicles to form the ejaculatory duct. Now, ductus deferens, thick walled tube, 45 centimeters long, arises from the tail of the epididymis, inferior pole of the testis, ascends behind the testes and medial to the epididymis. Now, you can see this picture. This is the prostate. Here is the bladder, the seminal vesicles. This is the rectopubic face. The lower dilated end is ampulla, joins with the duct of the seminal vesicle to form the ejaculatory duct. Ductus deferens, carrying away vessel, also called vas deferens. The ductus deferens is a long muscular duct that transports spermatozoa from the tail of the epididymis to the ejaculatory duct. Vas deferens. The vas deferens is a thin tube that starts from the epididymis to the urethra in the pelvis. It transports sperm from the epididymis in anticipation of ejaculation. Now, ductus deferens course. The vas deferens arises from the tail of the epididymis and traverses the inguinal canal to the deep ring, passes downwards through the lateral wall of the pelvis and almost to the ischial tuberosity, and turns medially to cross the ureter posterior to the bladder. It continues inframedially along the base of the bladder anteriorly to the rectum, almost to the midline, where it is joined by the duct of the seminal vesicle to form the ejaculatory duct. Here. This is the path, and it's open here, and this sperm spermatozoa is ejected. Now, blood supply. Artery supply of the artery to ducts difference in superior vesical artery, whereas drainage from plexus, vesicular plexus, lymphatic drainage, external iliac group of lymph nodes. Now, seminal vesicles. Seminal vesicles are two small fibromuscular pouches lined with columnar epithelium lying in the posterior aspect of the bladder. Here. The seminal vesicles contracts and expels their stored content seminal fluid during ejaculation. Now, seminal vesicles are accessory gland of the male reproductive system. Okay. The seminal vesicles are two lobulated organs, 2 inches, 5 centimeters long, lying in the posterior surface of the bladder. Now, seminal vesicles are sac-like structures attached to the vas deferens at one side of the bladder. Here, ejaculatory duct, seminal vesicles. The ampulla, ductus. Now, they produce a sticky yellowish fluid, contains fructose. Now, when there is a seminal analysis report, all these components like fructose, how much, this has to be analyzed, and the motility of the sperms, how many sperms are there, some millions. Now, I was telling you that to assure the male that your sperm count is less, but I need one soldier who will die. Die means you cyanide capsule खेले ना. So it is like that. We need one strong, so count doesn't matter. But there are some drugs in the allopathy system and so Ayurveda that increases the motility and also the quality of this spermatozoa. Now, the same description, blood supply of seminal vesicles, arteries, the arterial blood flow, supply from the inferior vesicle and medial rectal arteries, veins, the veins drain into the internal iliac veins. Ejaculatory duct. Ejaculatory duct are two tubes about 2 centimeters long. Each is formed by the union of the duct from seminal vesicles and a different duct. They pass through the prostate gland and joins the prostatic urethra carrying seminal fluid from the to the urethra. Now, ejaculatory ducts are ducts reach less than 1 inches long and the union of vas deferens and duct of the seminal vesicles. Next. See, this is another picture in sagittal section. Accessory glands, the seminal vesicles, prostate gland and bulbourethral glands. Now these glands produce nourishing fluids for the sperms that enter the urethra. Bulbourethral glands, Copper's gland. Now this can be a short note. The bulbourethral glands are 2 small glands located at the side of the urethra just below the prostate gland. This is the seminal collicles, prostatic utricle. Now these glands produce a clear, slippery fluid that empties directly into the urethra. Now the prostate